Module 4, Review. This has to do with our health assessment review based on the older adult. Health assessment of the older adult can be done through simple screenings to complex, in-depth evaluations. They're done to identify people that are in need of further, more in-depth assessments. They can include things like high blood pressure, monitoring their cholesterol, cancer screenings, osteoporosis screenings, hearing screenings, eye exams, disease screens, foot problems, problems with activities of daily living, depression and suicide risk screenings. In-depth health assessments are time-consuming, but never forget that there are times when just a short, focused assessment might be preferable if the client has a specific complaint. This information will then be used to identify client problems and a plan of care. Don't forget, this includes your objective and subjective data, with your objective being information that's gathered using your senses: vision, hearing, touch, smell, and it's collected by means of direct observation, physical examination, and lab or diagnostic tests. The subjective data is information that is gathered from the person's point of view, and it is best described in their own words. It's important prior to a health interview that we make the physical setting as comfortable as possible. We want the client to open up. We want them to talk to us, and the more comfortable they are, the more likely that is to happen. So we minimize distractions. Make sure that we have good lighting, comfortable furniture, it's private, a lack of interruption, that it's comfortably warm for the client, not for us, for the client, that it's free from drafts. Make sure that the client has their glasses on or their hearing aids in if they wear them. And we may need to assist them to the bathroom or mention that a bathroom is available if needed. Develop that rapport. We want to try and get information directly from the client and not family members or significant others when possible. There's some instances where those family members will try and take over the conversation. Those instances, listen politely, but then ask the client directly. Okay, I've heard from so and so, but now I need to hear from you. What are your thoughts, or how are you feeling? Because they may not have been completely truthful or open with their significant other, and the significant other may just be going on their observations rather than asking direct questions. Make sure that you greet the older person and introduce yourself. Use their name appropriately. This helps build respect and develop rapport. Explain the purpose of the interview. Again, focus on and speak directly to the patient. Speak to the others in the room as appropriate, but your focus should be on the client. Help the client maintain modesty. Standards will be different from culture to culture, so be familiar. And determine the client's biggest concerns. Focus on those first. Make sure that you plan sufficient time for the interview, and don't try to get too much done during a single interview, if it's inappropriate. If they're short of breath, you may have to just take what you can get. If they're having pain, you may not be able to get a lot of information. Whereas if it is just a routine annual exam, you may be able to get a lot of information. Use appropriate communication techniques to ensure that the client understands especially those therapeutic communication techniques. We want to encourage the client to open up and talk to us. Avoid medical language. Most people don't understand medical terminology, so don't speak to them with it. Make sure that you speak slowly and clearly. Use simple messages, but don't be patronizing. Be attentive and calm. Allow the client to complete their own sentences and don't interrupt them. And don't end an interview too abruptly. If necessary, set up a time for further interaction. We do try and get the assessment completed with every client contact. Personal cares such as bathing, toileting, pericare, or medication passes, or therapies, or feeding, or when we're just talking to a client, you should always be assessing a client. We should try and get the health history before the physical assessment if possible, because it helps identify the history of the concerns and their current health issues. But a lot of this is going to be dependent on the cognitive level of the client and the complexity of their particular medical concern. If the client is unable to provide answers, then move on. Don't sit there and wait and wait and wait. It's like, we'll just come back to this one. Maybe you can return to it later, but don't cause increased stress if the client is unable to remember. If family is available, you can always ask them later also. History will help determine the areas that need to be addressed or further explored. The objective information will be obtained during the physical assessment, and it can verify what the client has told you during the interview. Also, keep an eye on the client's mood and their behavior in addition to your physical observations. Make sure that you've gotten all of the necessary equipment before you begin, and develop that routine, maybe that head-to-toe approach, to make sure that you don't miss anything. Be systematic about your assessment. Those techniques include inspection, palpation, auscultation, and percussion. Inspection, once again, uses your vision, smell, hearing, and it's used to assess the overall level of function or detect specific areas of need within a particular area of function. Palpation uses the sense of touch in the fingers and the hands to obtain data. This could include pulses, temperature and texture of the skin, texture and condition of the hair, presence and consistency of tumors or masses, distension of the urinary bladder, presence of pain or tenderness. Always palpate painful areas last. Auscultation uses the sense of hearing to detect sounds that are produced within the body. Heart, lung, and bowel sounds are typically assessed with auscultation and involves the use of a stethoscope or another sound amplifier, such as a Doppler, to make those sounds louder or heard more easily. And then we describe those sounds according to their quality, pitch, intensity, and duration. And percussion. This is not something that is done by the LPN. It does require special skill and training. So with your physical assessment, start with your general inspection. Determine if there's any observations that might affect the procedure or accuracy of the readings. Get your baseline vital signs during that initial contact. Get the temperature. Older adults often have a lower core body temperature, so don't be surprised if it's a lower reading. Get the pulses. They should be obtained from a consistent position. If they're lying, get it in the lying position. If they're sitting, next time get it in the sitting position, etc. Whenever you check the pulse. And usually the radial artery is going to be the most common site where we check pulses. Assess and compare those pulses bilaterally. Remember that the normal rate is 60 to 90 beats a minute, and readings outside that range or significant changes may need further assessment. Irregularities are common in the older adult but may require further assessment. So remember, when you find an irregularity in your radial pulse rate, compare that to your apical heart rate. It helps determine perfusion. Get your respirations. We know that a range of 12 to 20 breaths per minute is normal. Slightly irregular breathing rhythms are pretty normal in the aging population. Significant abnormal findings do require further assessment. We should see, or if we see a decrease in the resting respiratory rate of the older person, this can indicate an impending infection, and we may see this before we see an elevation in the temperature. Chest expansion in the older adult is often decreased because of alterations in the shape of the thoracic cavity, muscle weakness, sedentary lifestyle, or other disease processes. Blood pressure readings will vary widely. We reduce false readings by being careful of the client's position, their stress levels, their pain, their exertion, eating, or smoking before we take those readings. Aging individuals are going to be susceptible to those posture-related changes in the blood pressure. We may do simple assessments of their vision and hearing ability based on empiric data. In other words, the way the individual will respond to visual or auditory clues. Observe whether they're able to read or do close work that require good central vision, or whether he or she watches TV or other sight-related activities. Talking can reveal difficulties with hearing. So if the client does not respond appropriately, it might be because they are not hearing you, not because they're confused. So try rephrasing that statement and state it in a lower tone of voice to see if you can get an appropriate response. Assessment of the level of consciousness should also be performed to determine whether an older person is alert and aware of their surroundings, to determine if they suffer from confusion, delirium, or dementia. We can do this by direct observation, those very simple questions, or some of the tools such as a mini cog, which is a highly regarded tool that quickly and effectively identifies cognitive impairments. We can also do neurological examinations to help determine brain function. So these help determine cognition, muscle strength and movement bilaterally, pupillary responses, level of consciousness, and reflexes. We want to assess their social function, so we observe the amount, frequency, and type of social interaction when it's possible. There is a tool that is used in extended care facilities called the minimum data set, which has been designed to improve the quality of care in these facilities and help improve and standardize assessment procedures. Basically what it does is reviews the long-term care residents' ability to perform their ADLs. The goal is to increase reliability, enhance accuracy, expand usefulness to improve clinical assessment. So it also helps caregivers identify problems, develop interventions, and monitor outcomes. Health status changes in the older adult can be very subtle, and they're not the same as we have learned to expect in younger adults. So early recognition and treatment of change in status can prevent serious harm for older adults. There are some different tools that have been developed to help with a systematic and comprehensive assessment for the older adult. So there's two acronyms we look at. SPICES, which addresses sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, and skin breakdown. The second mnemonic is fan capes. Fluid, aeration, otherwise known as oxygenation, nutrition, cognition and communication, activities or abilities, pain, elimination, and skin/socialization.